Okay. So the heart can be examined in the supine position or the left lateral position. So the first thing we're going to do is we're going to palpate all the peripheral pulses. So we're going to do the radial pulse, which is right here in the wrist. So bilaterally, we're going to check them both. Okay. Sorry, you got to lift your foot. Should have thought of that before. So we're going to palpate the, I don't know if you can see this, the dorsalis pedis, which is up here. So check them bilaterally. And then we're going to check the posterior tibialis, which is behind the ankle, bilaterally. Okay. So then we're going to auscultate over the heart area. So we're going to check the aortic area, which is over the second intercostal space, sternal border, right sternal border. So now the pulmonic area, which is just across on the left side. Erb's point is in the third intercostal space, sternal border. Tricuspid is in the fifth sternal border, and then the mitral is in the fifth space but mid-clavicular. So in order to hear the heart sounds, S1 is heard better over the apex with the diaphragm of the stethoscope in any position. S2 is heard over the base of the heart with the diaphragm in any position. And S3 and S4 are best heard in the left lateral position with the bell over the apex of the heart. So we're going to continue with the chest. We're going to percuss the posterior chest. So go ahead and just sit facing that way. Okay, now we're going to percuss the costovertebral angle. So what we're going to do is we're going to put our hand over the flank area, and then we're going to hit it with the other hand. Did you have any pain when I did that?
Nope.
Okay, same thing with the other side. Any pain?
Nope.
Alright, so we're checking for like kidney tenderness and things like that. Next thing we're going to do is the tactile fremitus. So this is where I put my hand over the patient's back. I can use the ball or the ulnar surface and ask the patient every time I touch you to say 99.
99, 99, 99, 99, 99, 99, 99, 99,
Okay, one more time.
99, 99, 99, 99, 99, 99, 99.
Okay. So now we're going to auscultate the lung fields. We're going to start at the posterior area. And go ahead and take deep breaths to your mouth. Okay, go ahead and face forward. Now we're going to listen to the anterior area. Same thing, breathe with your mouth open. Okay, Last but not least, we're gonna do the lateral areas. So lift your arms up. Okay. Go ahead and do the same thing. Okay. So now the next thing we're going to do is the abdomen. So we're going to have the patient lay down. So now the patient is laying down for the abdominal assessment. So we're just going to verbalize that we're exposing the abdomen. So just from looking at it, the patient's abdomen is flat, but rounded, scaphoid, or protuberant. I guess abdomens are normal. So normally you could shine a light over it to see, just to check for any masses. So we can see that it's smooth and symmetric as much as we could over the shirt. Striae in a patient that had lost a lot of weight or was pregnant can be normal. So the first thing we're gonna do is we're gonna listen to the 4 quadrants for auscultate. So we have vowel sounds. Over all 4 quadrants. Next we're going to auscultate the vascular sounds. So we're going to check the femoral, the iliac, the renal, the aorta, again the right renal now, the iliac, and the femoral. So no bruits were heard. So now we're going to percuss the abdomen. Okay, so we're going to check for the liver borders. So we're going to check on this side from an area. And percuss up till we hear dullness. So we can mark the area where we hear the dullness now with the marker or a tape if we don't want to mark on the person. Now we measure the area. 6 to 12 centimeters is normal. And we have about 7.5 for the size of the liver. So now we're going to do light palpation. So just small circles, checking for any bulges or masses. Do you have any pain?
Nope.
Now we're going to do deep palpation, same thing except a little. Do you have any pain?
No.
Okay. Now we're going to palpate the liver. So I'm just going to come around on this side. So put one hand underneath and then the other hand right underneath the ribs. And then go ahead and breathe in. Okay, sometimes you can feel the liver brush up against your finger, but I didn't feel anything. And that's normal. So another one is we can put one hand underneath to kind of lift them up. Put one hand underneath the ribs again on the left side. Go ahead and breathe in. Okay, this is checking for the spleen, and it's normal to not feel the spleen because the only time you will feel the spleen is if it's enlarged. Next thing we're gonna do is we're gonna palpate the kidney. So I don't know why I came around, but you're gonna do a duck bill underneath the rib. Go ahead and breathe in. So you could feel the kidney kind of bump up against your thumb, but I didn't feel anything. You can't feel the left kidney because it is 1 centimeter higher than the right kidney. So it's inside the ribs. Next thing we're gonna do is we're gonna palpate for the aorta. So it's slightly off midline. We're gonna check for pulses in the aorta. It's kind of deep. You could feel it in very skinny people, they say. So that was the abdominal assessment. We're now going to do the neuro assessment. Okay, the last part of the complete assessment is the neuro assessment. So the patient is sitting. First thing we're going to do is we're going to check the cranial nerve 11. So we're going to ask the patient to move his head against my hand. So against resistance, so he can push up against it. Do the same with the other side. Okay, now do the same, shrug your shoulders. Okay, perfect. So cranial nerve 10 is intact. 11 is intact. Next thing we're gonna do is we're gonna have the patient put his hands on his knees, and then we're gonna do pat, 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 and then do it as fast as you can. Okay, so that's checking for upper extremity coordination. Next thing we're going to do is we're going to have the patient put each finger to the thumb, like this. Okay, do it one more time. Okay, next thing we're going to do is you're going to take your finger and touch it to my finger, and then touch it to your nose. To your nose. Do it again. Do it again. Do it again. Now do it with the other hand. Okay, that's good. So next thing we're going to do is we're going to check lower extremity coordination. So what I'm going to do is I'm going to ask you to take your heel, and the heel of this leg, and drag it across the knee to the shin of that leg. And now do the same with the opposite side. Okay, so lower leg coordination is good. So now we're going to check some reflexes. We're going to check, I don't have a hammer, but I'm just going to verbalize the bicep reflex. So what we're going to do is I'm going to take the patient's bicep, and you just rest it on my arm. And so rest it on my arm right here. And then so what usually we're supposed to do is we're supposed to take the hammer and smack the thumb that's right underneath the bicep tendon. And then usually there is a reflex elicited there. So the other thing that we check is the patellar reflex. So my patient is tall and my chair is short. So normally what happens is we have the legs dangling off the side of the chair. Just kind of loosens up the tendon. So normally we do that. We would stretch the tendon and we would smack it right underneath the kind of the knee where the patella is, right here, and there would be a reflex where the patient would do it like a knee jerk reaction. So the next thing we do is the Achilles reflex. So I'm gonna have the patient, actually we gotta do this one. I gotta fix this. So now to check for the Achilles reflex, it's easier, I guess, if the patient is laying down. So we have the patient laying down and have the hips externally rotated and the knees bent a little bit. So what you do is you take the foot and you dorsiflex it. So we're kind of like, if you can see it, we're kind of like bringing it down. And then with the hammer you can hit the Achilles tendon. And then there's supposed to be a reflex where the foot jumps. The next thing that we can do laying down, also you can do the sitting, but since we're already here, is check the position sense of the big toe. So if the patient didn't have socks on, it would be easier, but usually what you're supposed to do is you take the big toe and you move it into a position, and then we ask the patient where it is. So what direction is your big toe?
It's towards me.
And now?
Towards you. Me. You.
Okay, so the patient has position sense. The next thing is we can do vibration sense. So if we had a tuning fork, we would hit the tuning fork, a low frequency tuning fork, and put it in the bony prominence right behind the nail, and ask them if they feel the vibration. If they don't feel the vibration, you keep moving proximal until they tell you that they do feel it. So now on the last part, we're going to have the patient stand, and we're going to check for Romberg. So what we're going to do is we're going to have the patient stand just like that with his hands to his sides. As you can see, he is not like waving, or he's stable in his stance. So now we're going to have the patient close his eyes. So there is just a small amount of movement, but he's pretty stable. So this is considered a negative Romberg. Okay. So the next thing we're going to do is we're just going to assess the normal gait. So we're going to start right here. Face that way. And just walk like you normally do. Come back. Okay. So the gait is smooth, rhythmic, and effortless, and the arms are, this arm swing is coordinated. So the next thing we're going to do is we're going to have him walk in a heel toe form. So just like you walk, just put one heel in front of the other. Okay, come back. Okay, so if he had coordination issues, walking in a heel toe decreases the base of support, so it will accentuate any problems. But he didn't have any problems. So that is the end of the neuro exam, and that is the end of the complete assessment. Of course, we wash our hands afterwards. And my name is Christine Rincon, and thank you very much.